Welcome to another WakeMed Guideline webpage and app Quick Take. Quick Takes are short videos introducing you to new guidelines. Today we will be discussing the FAST exam in trauma. Remember, the guideline webpage can be found at www.wakemed.org/SPG. It is mobile friendly and publicly accessible. If you haven't already, add it to your smartphone's homepage as an app. Today we are going to be reviewing the FAST exam in trauma. The purpose of the FAST exam is to rapidly identify free peritoneal, pericardial, and/or intrathoracic fluid. It is most useful in victims of blunt trauma, especially in the setting of hypertension or unstable vital signs. Remember that the FAST exam is not particularly sensitive for diaphragm, bowel or mesenteric injuries, pelvic trauma, or retroperitoneal bleeding. It is easiest to set up for the exam prior to the arrival of the patient. When using the Philips Affinity ultrasound machine in the trauma room, type emergent in the last name field and then enter the MR number into the patient ID field as noted by the green arrows. Then click close in the bottom right hand corner. Use either the curvilinear probe or phased array probe to perform the exam. In the example above, the curvilinear probe is selected. Select WakeMed FAST for optimal presets to perform the exam. For image orientation purposes, remember that the marker dot on the side of the probe corresponds with the blue dot in the top left corner on the ultrasound screen. For the purposes of this video, the blue arrow will mark the direction of the marker dot for each exam. There are 3 abdominal views, 1 cardiac view, as well as optional thoracic views in the FAST exam. It is recommended that the exam be performed in this order. There are 3 potential outcomes. In order to have a truly negative exam, all views need to be adequately visualized and without evidence of free fluid. If 1 or more views is inadequate, it is best to call the exam indeterminate. The first view to obtain is the Morrison's pouch view, as it is the most likely to be positive. With the marker dot on your probe pointing toward the patient's head, place your probe at the mid to anterior axillary line at about the 10th or 11th rib space. Angle toward the retroperitoneum to expose the kidney-liver interface. Be sure to slide your probe slightly superior to look above the diaphragm and slightly inferior to look near the inferior pole of the kidney as well. Here are 2 examples of positive Morrison's pouch views. In the clip on the left, you can see a large amount of free fluid in Morrison's pouch. In the clip on the right, there is a more subtle finding of a small free fluid near the inferior pole of the kidney and the caudal tip of the liver. Don't forget to slide your probe 1 or 2 interspaces superior to look above the diaphragm. The image on the left shows no evidence of free fluid. In the image on the right, you can see a large anechoic fluid collection consistent with a hemothorax in the setting of trauma. Additionally, the thoracic spine is now visible due to the presence of fluid in the chest. This is called the spine sign. Note that the thoracic spine should not normally be visible, as in the image on the left, due to interference from air in the lung. The next view is a suprapubic view. The probe's marker dot will remain pointed toward the patient's head. Place your probe just above the pubic symphysis and angle deep down into the pelvis. Look for fluid deep to and slightly superior to the bladder as shown. In females, fluid can also be seen behind the uterus as shown in the bottom right. Remember that a small amount of free fluid may be physiologic in women of childbearing age. The perisplenic view is perhaps the most challenging view to obtain. The key is to look very posterior, often with your hand touching the stretcher, to avoid artifact from air in the stomach. Although you may find fluid between the spleen and the kidney, the most important place to look is the area between the spleen and the diaphragm. With a large amount of free fluid, this may be obvious as in the image on the left. It also may only appear as subtle anechoic stripe as seen in the image on the right. Now continue on to the subxiphoid cardiac view. With your hand on top of the probe and your marker dot pointed toward the patient's right, place the probe just below the xiphoid and angle toward the patient's left shoulder. The bright white stripe around the heart is the pericardium, the location in which you will look for pericardial fluid. Note the difference between the 2 images here. In the clip on the left, a clean white pericardial stripe is noted. In the clip on the right, there is a large anechoic fluid collection consistent with a pericardial effusion. In some patients with abdominal trauma, it is difficult to obtain an adequate subxiphoid view. In this case, move your probe just to the left of the sternum at about the 3rd or 4th intercostal space, with your probe marker angled toward the patient's left hip. In the image on the right, you can see the bright white pericardial stripe in the far field of the image. Here are 2 examples of pericardial effusions from the parasternal long axis view. On the left is a small pericardial fluid collection, and on the right is a significantly larger one. Notice also on the right that there is diastolic collapse of the right ventricle, indicating the presence of pericardial tamponade. If concerned about pneumothorax, slide your probe to the second intercostal space at the midclavicular line with the marker dot again pointed towards the patient's head. Look for the bright white pleural line. In the absence of pneumothorax, you will see a shimmering or sliding between the two layers of the pleura, as seen in the clip on the right. Notice the difference between the two clips here. On the left, shimmering or sliding between the visceral and parietal pleura is visible, indicating that there is no air between the pleural layers, and thus no pneumothorax is present. On the right, you can see movement of the musculature of the chest wall, but no sliding of the pleural layers. This is concerning for pneumothorax. Please also note that lung ultrasound is sensitive, but not as specific for pneumothorax. Consider other causes of lack of lung sliding, including previous pleural surgery or chronic conditions that may cause the pleura to be adherent to the lung. The point to remember is that good lung sliding with respirations makes a diagnosis of pneumothorax much less likely. On a final note, for documentation purposes, please remember that all ED providers have access to QuPath Cloud. After the exam is performed on the ultrasound machine, open the QuPath icon on your Citrix desktop. Enter your password, which is the same as your Epic password. Find the exam that you just performed, fill out the worksheet, and sign it. This will send a PDF of your images and report to Epic. The report can then be found under the Imaging tab in Epic. That's it for today's WakeMed Quick Take. Thank you for watching. You can expect to see Quick Take guideline review videos in your inbox every few weeks. Please take a few minutes to watch them.